Hello, everyone, and welcome to today's webinar, Managing Multiple PFACs for Maximum Impact. This is the fifth webinar in our Get a Black Belt in PFAC series, where we explore strategies to help hospitals strengthen their patient-family advisory councils or start a PFAC. The name is based on my black belt in karate and the name of two books that I've written, one of which is Get a Black Belt in Marketing when I was in professional services marketing. And you can find the other four webinars and this webinar eventually, hopefully today or tomorrow, on our YouTube channel under Healthcare PX. I'm Barbara Lewis, and I've spent more than a decade researching PFACs, culminating in a mixed methods study on PFACs across U.S. hospitals when I was getting my dissertation. My interest in PFACs began more than 15 years ago after I spent 2 weeks in the ICU with my sister, who passed away very tragically. And since then, I've devoted my research and consulting to helping hospitals partner with patients and families to improve care delivery and outcomes. And I'll be sharing some of that research with you today. So please put your questions in the Q&A, not the chat. Your Q&A might be located under More in your Zoom menu. So one of the reasons why I wanted to have a webinar on this topic is that during my research, I discovered several hospitals that were managing multiple PFACs with a very small staff. And I was curious, how do they do this? So let me introduce our panelists. Kathy Hansen is the Director of Patient Engagement at the University of Miami Health System, where she and her team of 3 manage 10 PFACs. Katie Smith is the Manager of Volunteer Resources and the Patient and Family Partner Program at Stanford Healthcare, where 3 people manage 9 PFACs. And Julie Piazza is the Senior Project Manager in the Office of Patient Experience at Michigan Medicine, where she oversees 28 PFACs with a team of 4. So welcome, everyone. We'll hear from our panelists, and I'll share some of my research from my PhD dissertation. So let's take a look at those studies. So my first study was a literature review where I read 143 articles, dissected them, and they were from around the world, and it was quite interesting to see what other countries are doing with regard to PFACs. Canada actually has some great programs around patient-family advisory councils. That study was published in the Journal of Patient Experience. My second study was a qualitative study, and in this one, I talked to 20 U.S. hospitals about their PFACs and how they got them started and most effective practices and best practices. That's also been published. And the final study was a quantitative study that was published in the Journal of Patient Experience a couple of days ago, actually. And this was my quantitative survey where 220 hospitals responded, and those were U.S. hospitals. Okay, so let's get started with our conversation here. So let's start with the background of how or why you started so many PFACs. And Kathy, let's start with you.
Hey, thank you. And hello to everyone. Just by way of background, I need to tell you a little bit about my story. Very briefly, I became a member of the University of Michigan Patient Family Advisory Program, even though I'm at UMiami in Florida now, because I have a son who's on the autism spectrum. And I was asked to be a co-chair for one of the PFACs. Through my work at Michigan, I was also invited to become a member of a PCORI, Patient-Centered Outcomes Research grant that was based out of Brigham and Women's Hospital. So I got familiar with their patient and family advisory program as well as the one that they had at Dana-Farber. And then I became very involved with PCORI because it's another way to engage patients. And this is patients engaged as participants versus subjects in research. So I was recruited I met my future boss at Brigham and Women's. I was recruited to U Miami to create a patient and family-centered care program. There was an oncology program that existed, but really no infrastructure at all. It was created prior to having a program. So that meant that awareness of patient and family-centered care was pretty limited, just knowing that oncology was the only program. And during COVID, obviously, we couldn't really do anything in person. And so during that time, we created an e-advisor program, which I mentioned to you a little bit, Barbara. And through that program, we were able to recruit a very efficiently a very large number of patient and family advisors. So we started from there and created our first PFAC beyond oncology was a facilities PFAC because U Miami was growing and building new buildings. And so we recruited through our e-advisor program people to participate and go around and give advice from the lens of a patient or family member, advice about the buildings that were being built. And we just continue to expand awareness of the value of the patient perspective and the voice of the patient in a wide variety of groups. So
Thank
that's how we
you.
got started.
So, Julie, let's go to you with 28 PFACs. What was the background of how it got to 28? You obviously started with one. Tell us a little bit about that, please.
Yeah, so thank you for that. Appreciate it. So I have also my journey a little bit into this in the background might be helpful. So I'm a clinician and a researcher as well as a project manager within the Office of Patient Experience, and I started my work in as a certified child life specialist at University of Michigan in 2001. And I think over the years, through my training and education, which really encompassed a lot of patient family centered care and working closely with Bev Johnson from the Institute for Patient Family Centered Care, the movement of patient and family centered care is not new to me as a clinician, but also expanded over the years. And our first work was really looking at how to bring this first to the Children and Women's Hospital. So I was part of that, and then expanding throughout the institution. And I will say, please, there's a dynamic, robust team behind me and with me and in all of this. And our team, which is the engagement team of the Office of Patient Experience, really helps to shepherd and support. And, you know, in terms of how did it grow to 28, people put their hands up, wanted to be involved. They caught the fever and wanted to really be a part of that and help improve care and improve experience for not only patients and families, but obviously staff who make that the ideal experience. So I think that's really how it grew, and I'm happy to expand on that later.
Yes, yeah, we'll get into that. So people put their hands up, but maybe not everybody who puts a hand up gets a PFAC, and we'll talk about that. Katie, what about you?
No. Yeah, that's true.
Sure. So for us at Stanford Healthcare, we launched our first PFAC in 2009. And it kind of like Kathy, it was because we were expanding, we were building a new hospital, and we really wanted to have the patient and family voice kind of help us with that design and the launch of that new building. So we did launch in 2009. I think we started adding additional PFACs shortly thereafter. And similar to Julie, people caught the bug. They just were interested. They thought it was really important to continue to engage with our patients and family members and really embed that into their culture. So we had several other PFACs kind of launching in the years after 2009. Some of them launched for different reasons. So, for example, we had a PFAC launch because they were looking for additional accreditation, and having a PFAC was a required part of that. So that is also kind of contributes to some of our PFACs, but we do We do look at that when that comes up because we, of course, want to make sure that we aren't launching PFACs just to check a box. So there is a lot of kind of background and planning and research that goes into that. And we wouldn't always say yes to someone who was looking to do something like that or to create a PFAC, again, just to check that box. So we currently have 9. We'll be launching our 10th hopefully soon in the next couple of months. And so it's been kind of an evolving process ever since then.
Mhm. We're going to get into more questions around that soon. So, Kathy, you mentioned e-advisors, and I just wanted to say that this is going to be the next webinar that we have in March and how PFACs are using e-advisors. So that's where there's usually a survey. Do you want to participate? And hospitals have thousands of people who have said yes, they will answer questions. So that's going to be upcoming. And I'm going to show a slide on that so you can actually sign up for it if you want. Okay, so let's move into the second question then. And this is, what type of PFACs do you have? So in my research, I divided PFACs into general, and which is unfocused, and that covers the entire hospital, a general PFAC usually, and then focused ones, which are based on a condition such as diabetes or population such as youth or both. So let's talk about what you have. So Julie, what do you have in the 28?
Yeah, so we have specific, we have a cancer center, PFAC, we have a cardiovascular center, so condition specific. We also have a children and women's hospital specific, along with, we just merged with the children's emergency services and adding that to that group. And then we have out in primary care, we have primary care PFACs for a particular area, region. We do find when it's a condition specific, like for example, the cystic fibrosis group, they really rally together. They have strength, and they, definitely utilize national connections and help to their PFACs to grow. And I think that really benefits. But we do have some in general for the adult hospital, for the children and women's hospital, and primary care is specifically usually in a particular area.
Katie, how about you?
Does that answer?
Yes, yes.
Sure. So we currently have 4 categories, and we're not exclusive. So if we needed to expand, we could definitely do that. But our categories include specialty. So that would be things like specialty care, cystic fibrosis, adult congenital heart disease. We have an emergency medicine council. Our second category is what we consider hospital-wide. So more kind of general oversight or processes. Those are our founding PFAC, the initial PFAC that we founded. We have a disabilities PFAC that looks at ADA and accessibility issues across our organization. And then one location specific in our East Bay area, our Tri-Valley PFAC. Third category is around transplant. So we have a couple of transplant PFACs. And then finally, cancer. So we have both an adult cancer PFAC as well as an adolescent young adult cancer PFAC.
So are the transplant PFACs by organ?
Yes, so we have a heart transplant PFAC, and we have a lung and heart-lung transplant PFAC currently.
Okay. Kathy, how about you? What do your PFACs fall under?
Well, similar to Katie, and with some similarity to Julie, because that's where I learned about patient-family centered care. We have our disease-specific PFACs. We have adult and adolescent oncology PFACs, for example. We also, within that category, have a newly launched caregiver PFAC. So we have both staff and patient and family advisors who participate in that because we're seeing an opportunity for retention by thinking, what do our staff need, who are especially in that sandwich generation. We also have federally mandated PFAC. So we have the CMS patient safety structural model PFAC, which is focused on safety and meeting the requirements of the federal government. We have multidisciplinary PFACs, so we have 3 very large multidisciplinary centers that are location specific, but also have an overlap with each other. Each one of them has a cancer clinic or has a diabetes clinic or an eye focused clinic. So we are figuring out how to do all of those. We have what I call resource committees. So we have a facilities committee that helps with new buildings, but we also, one of our more successful groups is our communications and technology committee. So that group reviews, working with my third team member, looking at any kind of patient-facing document or video or whatever modality the information is in, to give their feedback before that's launched. And then we're also looking at technology. We're very mindful of the impact of AI and new technology being launched, and we want to make sure that we are getting the voice of the patient, regardless of what age range they're in, their culture, their language. All of those things have to be considered as we're launching things like that. And then finally, we have appointments. They're not really PFACs, but they're part of our program, and that is what we call our quality and safety committees. So we have patients who serve on our ethics committee, on our grievance committee, and our patient safety committee. So it's a wide range of groups. And then we have a list of about 10 that are pending that fall within different categories. And as my friend James Harrison always says to me, be mindful of capacity. See, James, I listen to you. Because we are a very small team and we try to keep up with everything and do best job we can.
Wow, 10 pending. That's that could get overwhelming, I guess. So I just came from the Vive conference here in Los Angeles, which is healthcare tech. And I was really very surprised of the 500 vendors, and many of whom I spoke with, just going around the exhibit floor. They are not using patients in their development or their design of AI or other technology. And I've actually got a podcast, Tech Designed with Patients, because I'm interested in who is including the patient voice when they're designing tech. And of course, they should be. That caregiver PFAC is very interesting, and I have not heard that before. If you have one, if you're on and you have one, please put it in the chat. I'd be curious to see how many of you have caregiver PFACs. Okay, so I'm working with 3 monitors today, so hence my eyes are going back and forth. And I am going to show the research, what the research results show. So on the survey, when I asked if you had a focused PFAC or an unfocused one, so an unfocused one is the general hospital one, and the focused one is if it's a condition or population. 30% of the respondents said that they had a focused PFAC, and 70% said that they did not, that they had an unfocused PFAC that they were responding for. And then when I did some analytics and asked and actually examined the analytics, what I found is that the focused PFACs were much more effective than unfocused PFACs in 6 different areas. So focused PFACs had more content. Their agendas were more full than unfocused PFACs. They had pre-meetings with the departments who came in to talk to them about what they wanted to discuss with the PFAC. There were pre-meetings. They tended to measure the results and the outcomes more frequently than unfocused PFACs. The engagement level, which I define as stamp of approval, feedback, and co-design, they were much more engaged toward the co-design and the feedback than they were on the stamp of approval, which some hospitals said to me is not very good to have that, and they actually don't allow departments to come in that are just looking for stamp of approval. They say it's not very respectful of the PFAC. There was more involvement in decision-making with a focused PFAC, and there were more metrics and measurement and process and outcome metrics. Okay, so let's now take a look at the next question, and let's get into how you manage all those PFACs and what's the key ingredient to your successful management. So, Katie, let's start with you.
Sure. So for us, there's a few key ingredients. I know Michelle had asked a question in the chat about what else do we do. And my team, we are a team of two. We oversee all the volunteer activity at our hospital and clinics, and that includes our PFACs. So we're not just PFAC focused. So for us, one of the key ingredients is really having staff advisors who support each of our PFACs. So we do have an individual person to sit on the PFAC as a staff advisor. They really help with things like logistics and bringing in guest speakers and creating that connection with either the clinic or the area that they're serving in. I am not an expert in transplant, so I can't provide any information to the PFAC around what's going on in that clinic. So really critical to have a staff member dedicated to the group. So that's really important for us. I would say the second piece is that we have a structure in place, but it's a little bit loose and adaptable. And I think this is really important for our PFACs because some of them like to do things differently. We used to have a set of bylaws, but again, it didn't allow a lot of flexibility for each of our councils. So we changed the name of that document to operations and best practices instead of bylaws. So if a PFAC wanted to do something differently, they could alter that document and make decisions that were really going to be beneficial for that group specifically. So we found that to be helpful. Having kind of a loose structure also provides guidance to those who maybe don't want to go off script and do their own thing. They really want to follow a structure. They're able to do that as well. Um, I would say communication absolutely is really, really important. We do a lot of communication by email with all of our members. We also get each of our PFACs together quarterly. So we call that our PFAC board. It's the chair and the staff advisor from each of our PFACs. We meet quarterly to talk about best practices, anything that's new and different, any updates we have to the program or the organization as a whole. But it's really just a great way for everyone to get together. I think they draw a lot of inspiration from each other. So thinking about like, oh, I had no idea we could host an education event for patients. And so really kind of just getting information and ideas out there to the group, as well as sharing best practices. How do you handle maybe a member who's a little bit disruptive? So it's a great forum for that type of interaction and information sharing. I'd say those are probably the top three key ingredients for our PFACs.
Great. So you mentioned that you have staff advisors who support each of the PFAC. Where do you find these people, and are they volunteers or are they assigned, and how does that work?
Yeah, it depends on the PFAC. A lot of times we get staff members who are just really interested, and so they will volunteer to participate. Sometimes we have a clinic or an area assign that person. We've gone back and forth on who is the best person, and I think it just depends on the person. A lot of times we would have a clinical staff member kind of start in that role, and then it becomes very clear that they're just too busy to be able to kind of add that to their plate. So um, an administrative person usually works out a little bit better. But again, it does just depend. We've had people in the staff advisor role since the inception of a PFAC. So, 10, 11 years, and they just enjoy it so much that they've continued to do it. But we do think it makes a difference. If a staff member is kind of voluntold that they have to take on this role, it's not usually as successful as some of those who have a staff member who's, just generally engaged and believes that this work is really important.
So I found that to be true in my research as well. So one of the things that I was interested in is if you are assigned, voluntold, or if there was some kind of competition or questionnaire or application, for example, and what my interviewees told me is that the voluntold PFACs are a lot less successful when there's an application process of people who really want to be on the PFAC and raise their hand and try to get on it. So that the research is the same as that too, Katie. Thank you. So Kathy, what about you? What do you think is the key ingredient to successfully running so many PFACs?
I think just mirroring what Katie said, I think communication is key, and then participation is key to keep things going. So what my team does is we attend every PFAC meeting as much as we can. We do have staff that lead those committees, and like Katie, we don't have formal bylaws because we found that each has its own personality and reason for being. We also look to our patient and family advisors to see if there's someone who wants to be the co-chair, who can take some of the burden of managing the day-to-day things like getting the agenda out, reminding people of the meeting, inviting speakers if they're going to have them. So that's really important. We also have created systems and tools to manage all the moving pieces. So the advantage that we had in starting this program is we had nothing, and we built the sidewalk as we walked on it, as the saying goes. And we have, as we've expanded, we've adapted also to how do we manage all of this. We are required by our Office of Patient Experience and other leadership to report quarterly on what the status is, and we work with various leaders to make sure that we're prioritizing our work. So we're very mindful of our limited resources, and we want to make sure that we're spending our time in the place that makes the most sense from an institutional perspective.
So you said that you attend every PFAC meeting. So what's going to happen when you add 10 new PFACs? Are you just going to be at meetings all the time? How is that going to work?
Well, I think what we'll do is probably have to rotate. We divide and conquer right now. While there are three of us, myself and the key staff person who manages our PFACs, the day-to-day work, we split it up. Our third person is primarily focused on health literacy and patient experience, patient education. She leads our communication and technology PFAC herself, and where we need her, she can step in, and we can step in for her as well. So we cross cover each other. So in answer to your question, we obviously will not be able to attend every meeting, but where we can, we do, and we have quarterly meetings with all of our leaders, and then make sure that we're communicating as much as we can. We just have to be more and more efficient and find ways to do more with less, is the bottom line.
Yeah. So Julie, with 28 PFACs and only a few people, what do you feel is the key ingredient to your successful management of all of these PFACs?
Well, I will say that it is definitely a team effort, and as Darnassus mentioned in the chat, this team is not solely focused to PFAC management, but we are doing other roles in terms of, training and overseeing advisors and recruiting, and we do story recordings, and we have a peer mentor program that is very robust and bigger than the PFAC. And I think in terms of the project work, how we do it, and I think do it well, and is ditto kind of to what Katie and Kathy have both said. We do have a quarterly PFAC lead meeting with the leaders of those PFACs coming, and it's very well attended. And we bring things to that meeting to help share the best practices, provide guidance and support. And also, one of the most recent things that we did was really to create more of a cultural awareness. So we have a very robust interpretive services program that is part of the Office of Patient Experience, and sharing the interpreter role and how they can help us to recruit and support advisors from different cultures and make sure that we are representing our patient population was really key. So that's been wonderful to see. And I think as was mentioned, the standardized processes, but also with flexibility. We have a charter that we provide for people when they start out. And then that is really part of the business of really starting the PFAC and getting it up and rolling, is how do we live into this mission and tie it to our institutional priorities. And we've added our project management team to serve as liaisons as well, so we can, further solidify the projects that we're working on in the institutions to tie that into the PFAC, and in terms of topics and awareness and feedback and insight. That's been truly very helpful. So those liaison roles are also in addition to our team, which is now a team of 3. But we have just wonderful leadership. And I think, someone mentioned about just even who is engaged. So in terms of, we have found the same. If someone was voluntold, that doesn't necessarily work as well. But we have really been able to identify people that have worked with us on projects who are very good at what they do, and suggesting, would you be interested in exploring or visiting or leading? And that has worked very well. We just had a new person come on as a lead of the Adolescent and Young Adult Advisory Council, and it's just truly wonderful when that works.
Great. Yeah, that project management sounds interesting. I'm sure we could have an entire webinar on that.
Yes, we could.
In terms of recruiting and supporting advisors, we did that webinar a couple of months ago. It's on YouTube if you're interested in how hospitals are recruiting so that their demographics on the PFAC actually match the demographics in the waiting room. So that's on the YouTube channel, Healthcare PX. Okay, so now let's move on to, suppose a department comes to you and is interested in starting a PFAC. What happens next? Kathy, you want to start?
Sure. So we have a process that we follow. It's a series of steps. We initially meet with the team requesting and make sure that we understand what they're looking for, and what their expectations are. And we refine expectations. This is what we'll do. This is what we need you to do. Once we have that clear, we send our e-advisor recruitment survey out. We jointly create that. So an example, just to give you an example of one right now, this is a more challenging one where we're looking for a specific set of patients. We're looking for head and neck cancer patients, because there's some work that is being done in that area. That's not going to be easy to recruit for, but we'll probably get a large number of people coming. We review the responses. We make sure that the team that they're going to work with get how we rank them is ABC. We give them the A's. And I just want to make a quick comment about that. We're a relatively new program. The awareness of patient family-centered care here in Miami, which I call South of South, is not as broad as it is in Michigan or on the East Coast or the West Coast. So what we do right now as our priority is we recruit the most experienced people we can find, and then we build the program out with the patients that don't necessarily have the same scope. Because we have to overcome the bias that sometimes exists. Like, why are you inviting patients to talk about these things? That makes people feel really nervous.
In the hospital, you're saying?
Yeah.
The hospital employees, yeah.
Yeah. And then once we get that group together, we hold a orientation, obviously with the new patient advisors after they've gone through onboarding. And then the next step would be to have a meeting of the staff that have been recruited to be participants in the PFAC, to make sure they are comfortable with engaging with patients in a different way than maybe they have before. And we launch a kickoff meeting, and then we start working with them as they refine their process, developing their agendas, making sure that they're truly engaging patients, working with them, not just doing things for them or giving them the information and saying, this is how we're going to do it. And that's typically where people start, and then it's a refinement process as we go on.
So you said that you're now looking for head and neck patients that have
Mhm,
cancer.
mhm.
Are you going to the EHR and identifying there and then reaching out to them? How does that work?
That's a really good question, and the answer is no, and the no is purposeful. We make sure that patients know that we know nothing about them other than the fact that they have agreed to be part of the program. What they share with us is fine, but we don't need to know their daily visits. We don't go into the Epic. We don't have access to Epic on purpose because we want everyone to be able to feel comfortable that their patient information is private. And part of the reason for that is UMiami gets a large number of um, what we call high profile patients. And so we're very respectful to privacy.
See. So I got a question the other day that the person was looking for specific people that had certain condition for a PFAC, but she could not access the EHR and she was not allowed to. They would not let her. So what I'm finding, and is this what happened to you, Kathy, is that there's a mass email that goes out, will you help us? And then from that, there's another email that then goes out, if you have head or neck cancer, would you be interested? Is that the
So,
process?
sort of, with our e-advisor program, we've really refined how we recruit. So we send surveys that say, for example, have you been treated at UMiami in the last 12 months? I'm making that up. If so, we're looking for this specific diagnosis. And right now it's head and neck, but we've had cystic fibrosis, we've sickle cell, some harder populations as well as easier populations. Are you a woman who's been treated at UMiami? And then we start asking refining questions. And that's what tells us who's out there. And we always include an open-ended free text question so that we get a sense of how the patient communicates.
Oh, interesting. So can you share with us how many people are advisors?
Right now, in our program, we just reduced our number because we had some patients who were ready to sign up. So we have about 59 active patient and family advisors right now. And in our e-advisor program, we have 4,100
Wow.
patients. But
So that's
that's,
quite a pool that you can go out to when you're searching
yeah,
for a specific condition, for
it
example.
is. But
Yeah.
one caveat, and I'm sure this will come up when you talk about e-advisor programs, you have to be mindful of the fact that the people that respond to want to be an e-advisor don't necessarily represent the full demographics of your health system, because they're people who want to answer surveys.
Right.
And that's not full. So we have to expand that by also working with our staff to tell us about the patients that they meet.
I see. Okay. So that's working in combination.
Mhm.
So, Julie, so with the 28, now suppose the 29 comes to you as a department and says, "Oh, we've seen what 28 are doing. It's fantastic. We'd like to start one." So, what happens next with that?
Yeah, so very similar to Kathy, just in terms of meeting, meeting with the people that are requesting, talking through, because what we've found sometimes is that maybe they don't really understand all
Mhm.
of the things that go into creating a PFAC and sustaining a PFAC. They want an answer maybe to a specific question. They might want a focus group. They might want a particular, or maybe they could be incorporated into a larger PFAC or, in terms of that representation and still get the same benefit. So we really try and, assess what the needs are at that. And then also we also have a very robust e-advisory, similar to, Kathy and Katie, how we have newsletters, we have emails, where we're identifying a particular need, as Kathy mentioned, similar to that, and identifying, patients and families that would have that situation particularly. We've also gone to staff meetings and talked with the providers, and talked with them and helped them to identify, how to approach someone if they have a patient that would really, be a beneficial advisor and they have a lot of experience and that they would be willing to share. A lot of times those providers are really the link and the key to getting those advisors to be partnered on that. Sometimes, providers are not comfortable or don't know the language, so we provide and coach, them along with that. And then we have our communications team is helping to identify a flyer that is more of a general, and then we sometimes will do specific for particular areas that people can post in a clinic area or have available for a patient to take and talk about. And then I would also say Patient Experience Week is a great way for us to just highlight all of the things that we're doing and increase awareness of the advisory councils, what it takes to put those together, what it means. We have learning forums all the time that, really PX 101, how do you do this? Why is it important? And getting the foundation laid for future growth. And I think that's one of the things that we really try and assess is, do you really need a PFAC or want a PFAC? Will that be the most benefit for your particular area?
If anybody has the dates for Patient Experience Week, I don't know it off the top of my head. Please drop it in the chat. That'll be helpful for everybody that they can design some programs around that, especially recruiting. So Katie, anything new to add on?
No, our process is very, very similar to Kathy and Julie. We get the same, oftentimes people don't understand what a PFAC is, what it takes to stand one up. And so we do that initial meeting. We also, as part of our program, we offer to support those one-time or ad hoc engagement opportunities outside of PFACs. So oftentimes they'll say, oh, I didn't know you could help recruit us patients for a focus group, right? And so we can just explain to them that that's an alternative into actually starting a PFAC. However, if a team did decide they were ready to go through with it and they really wanted to commit to starting a new PFAC, we do have a roadmap on what we would ask them to do before we would actually launch that. And I find that to be really important because we know that if we're launching a PFAC either too early or without a focus or without the right staff people at the table, we're kind of setting them up for failure. So we want to make sure that we take that slow and we really do kind of follow the roadmap that we have put in place.
So let me just stick with you, Katie, and ask then, some PFACs are probably more successful than others, but what would you say is a characteristic of successful ones?
Yeah, I think we talked about this a little bit earlier, but that staff advisor, they're really critical, I think, in helping us to make sure that the PFAC is successful. Again, just that leadership buy-in, keeping members engaged, making sure that they, don't feel like outsiders. They feel like they're part of the organization because they are. We want them to be really ingrained into the work that we're doing, understand our goals, and so really just really ingraining them into the work that we're doing, I think is pretty important.
And Julie, how about you? What's a characteristic of successful PFACs?
Successful PFACs are, I would definitely have to go with engagement. I think when that is key, when that communication and partnership, we get together for some of the ones that were more stronger, liaison partners to, we'll get together 2 weeks prior to the meeting, ensure that the agenda is put together with all of the co-chairs. And for some patient advisory councils, we have 2 patient family co-chairs so they can spell, each one, and that works well. We also have others where they have decided to take on a role that there's a co-chair with the staff co-chair, and then there's a secretary helping with the minutes and a person who can, meet, and it's almost like a little core team. And that really has been successful for some of the areas. I think also the key is bringing things that bringing things to that meeting and ensuring that it's something relevant, that it's something that can be utilized, that the team in place has experience with that, and how and would very much, some of the things, that don't work are, like someone had said, oh, here's our building and we're cutting the ribbon tomorrow. What do you think of it? I mean, it's like more, it's more, like we really want to be in part, they want to get their hands dirty and just figure it out when it's messy in the middle, and just sort of be a part of that and help to create new things. So I think that's really great. And I think just the fact that since the pandemic, many of our PFACs are virtual now, and we have really appreciated the benefit of that, just in terms of people being able to join and being able to get that representation from a more diverse community partner, population as well. I mean, our hospital is in the Midwest, but it's also not always easy to drive, and people come from a great distance sometimes. So I think that is truly, and it's truly been a wonderful thing for everyone, I think.
I see we are at our time now. Woo-hoo. So
Wow.
thank you, Kathy Hansen from the University of Miami Health System, Katie Smith from Stanford Healthcare, and Julie Piazza from Michigan Medicine. And thank you, Julie Strider-Cook, Director of Patient Provider Employee Experience at Mercy General Hospital, for helping with the webinar logistics today. The next webinar is Scale the Patient Voice, Why E-Advisors Matter. So let me drop into the chat this, hopefully I'll be able to do this, the way to sign up for that if you want to do so. That's on Thursday, March 26th. And here are my coordinates if you're interested in getting in touch with me. I would love to hear from you. Some other resources here, the YouTube channel, it's Healthcare PX. You can just go to YouTube and put that in. And here's all the articles that I've written. Let me drop that in the chat, as well as potential resources for you. Okay, thank you everybody so much for being online today in this webinar, and thank you again to our panelists. I really appreciate all your support. Thank you very much.
Thank
Thank
you.
you.
Thank you.
Bye.